will enlighten us on local anesthetic toxicity.
Good afternoon. It's a pleasure to be here in Pune. This afternoon I'll be speaking on local anesthetic systemic toxicity. I want to extend my greetings from the city of Hartford. Hartford, as you know, holds a special place in the history of anesthesia. It was in Hartford that nitrous oxide was used for the first time clinically on patients by Horace Wells, who was a dentist. And these are some of the monuments that honor the memory of Horace Wells in the city of Hartford. The objectives of this lecture is to discuss the prevention, recognition, and management of local anesthetic systemic toxicity, and to review some of the recommendations of lipid rescue therapy. As you all are aware that local anesthetic toxicity is a rare but a catastrophic event, and with the increasing popularity of regional anesthesia, it is important that all anesthesiologists become familiar with the management of local anesthetic toxicity. So here's a patient that is ready for a block. He's hooked onto all his monitors, EKG, blood pressure cuff, saturation monitor. He has a running IV, and we've given him some supplemental oxygen, a mild sedation, because you don't want to give deep sedation. You might mask some of the symptoms of local toxicity. But before you actually proceed with the block, you should have, within close proximity, be prepared for local anesthetic toxicity, and you should have a cart or some kind of a setup where everything that you need to manage the toxicity is close by and in one place. So we should have a crash cart that has equipment to manage the airway, emergency drugs, defibrillators, and as well as you should have lipid emulsion and a rescue checklist. It is important that when you have emergencies, you should not rely on your memory to be able to follow all the steps and remember all the dosages. That way you might miss on important aspects in the management of the toxicity patient. So it's important to have a checklist in the area where you do perform all your blocks, or where local anesthetics are used. In 2008, Weiberg and his colleagues, they sort of demonstrated that by having intralipid 20% solution made from soybean oil and from egg yolk, they were able to prevent local anesthetic toxicity by pre-treatment, or facilitate the management of toxicity when given after the toxicity had occurred in intact anesthetized animals. So here's an EKG of an animal that's been anesthetized. You have the EKG down here and the arterial blood pressure reading, and you give the animal a bupivacaine bolus. And what happens is, within minutes, the heart rate starts to slow down. You can see the blood pressure is starting to slow down. The heart rate is coming down, and ultimately you have bradycardia, and then you get into an asystolic arrest. And that's what happens when you're going to have a local anesthetic toxicity, and you basically end up with a flat line. So CPR is started, and when you start your CPR, if you have good CPR, cardiac compressions, you might see some pulses on your arterial line. No independent rhythm. They continue with the CPR. And with no independent rhythm, a bolus of the first bolus of intralipid is given to the patient. They continue the CPR to distribute the intralipid to the target tissue. And you can start seeing some independent or spontaneous activity of the cardiac muscle of the heart now. And as you continue your resuscitation, you have to make a decision whether to give a second bolus or to start an infusion. And in here, a second bolus of intralipid was given. And the resuscitation is continued. And now you start seeing more and more spontaneous activity of the heart, with the blood pressure being sustained. An infusion is started. And within minutes, with the lipid therapy, you have a normal beating heart, spontaneously beating heart, and good blood pressure. So you essentially have full recovery with your lipid rescue therapy. This was recorded in an animal model, in an anesthetized animal model, but this is basically the scenario that you'll be facing when you have local anesthetic toxicity in your patients. The mechanism of action of how the lipids actually work is that it acts as a sink, lipid sink, whereby it grabs on all the local anesthetic molecules and pulls it away from the target receptor sites or the target sites where it causes its toxicity. There are other reasons as to how the intralipid works. It offsets the inhibition of fatty acid metabolism by the local anesthetics. It is a transient cardiotonic effect. It reduces the inhibition of sodium channels, and it attenuates post-ischemic cardiac reperfusion injury. And so these are some of the other sort of mechanisms apart from the lipid sink that's been postulated in facilitating resuscitation. The reason why you get local anesthetic toxicity is because you get toxic blood levels of local anesthesia, and that can be either because of unintended intravascular injection or because of absorption of local anesthetic from the site of injection. And there are certain types of blocks which increase the risk of higher or have the higher blood levels. Spinal being the lowest, and intercostal and intrapleural give the highest toxic level, so you have to reduce the dose or be very careful when you're administering one of these blocks that give rise to higher blood levels of local anesthetic solution. And then there are certain patient factors that also contribute or increase the risk of toxicity. Now, the patients who are at increased risk are those who are with advanced age, cardiac factors. There are certain metabolic diseases, liver diseases, low plasma protein, acidosis, and medications that inhibit sodium channels. And in those cases, it's important to reduce the dose of local anesthetics, especially in the older and the sicker patients. And that should be the takeaway lesson. While you're actually performing the block, you should follow some of these recommendations that will help you in preventing intravascular injection or decreasing the or lowering the risk of toxicity. You should always start your injection with a test dose. You should add epinephrine as a vascular marker. You should aspirate before you inject. You should inject incrementally. You should reduce your total dose, and as you heard this morning, ultrasound guidance is a good way of trying to reduce the amount of local that you need without having any deleterious effect on the quality of your block or the duration of your block. While you're injecting, you should maintain verbal contact with the patient. You should observe the signs of toxicity, and you should continue to monitor the patients after the injection has been done, because you can get toxicity, after the block is done and the patient is waiting to go to the OR, and you can have toxicity then. So you should continue to monitor the patients. The classic descriptions start off with some non-specific symptoms like visual disturbances, lightheadedness, numbness, and tingling, and they go on to excitement of the CNS, and then they go on to the cardiovascular toxicity. In the classic description, the CNS excitement always precedes the cardiovascular collapse, but this is actually not true. In only about 40% of the patients, the classic presentation is seen. In the majority of patients, you can have cardiovascular collapse as the first symptom of your local anesthetic toxicity. So there is no predictable sequence of symptoms. The symptoms, as we said, can develop 5, 10, 30 minutes after the injection, and so you should continue to monitor these patients after the block is placed and they're waiting for their surgery. You should suspect local anesthetic toxicity in patients who have altered mental status, neurologic symptoms, and cardiovascular instability. And some of the central nervous system, central CNS symptoms are non-specific excitation and depression, and what they ultimately lead to is seizure and basically coma. Similarly, in the cardiovascular symptoms, you get bradycardia, conduction blocks, asystole, and ventricular arrhythmias, and basically you'll end up with cardiovascular collapse. The management of local anesthetic toxicity begins with, you should try to get help, secure the airway, ventilate the patient with 100% oxygen, If the patient is seizing, suppress the seizure usually by using benzodiazepines. That is the preferred way. If you don't have benzos available, you can use smaller doses of propofol to suppress the seizure, though in patients who have cardiovascular toxicity and have low hypertension or cardiovascular collapse, the propofol is not sort of advised. So benzos are the preferred method. And if you have a facility close by where you can put the patient in cardiopulmonary bypass, you should alert them of the possibility that you have a patient with toxicity who might have to be put on bypass. For management of cardiac arrhythmias, you start with your basic and advanced cardiac life support systems. You might have to do a prolonged resuscitation in these patients. While you're doing you're managing the cardiac problems, you should remember that epinephrine, when you use it for your ACLS protocol, you should reduce the dose that you use. You shouldn't use the standard 1 mic per kilo, but you should reduce the amount that you use. Vasopressin is not recommended. The higher doses, they increase the SVR, and in the face of toxic cardiomyopathy, they may impair your resuscitation. You should avoid drugs like calcium channel blockers, beta blockers, local anesthetics for management of arrhythmias. Amiodarone is the preferred drug if you have to manage arrhythmias. You can initiate your lipid emulsion therapy the sooner the better. Start off with a bolus of 1.5 mLs per kilo. In an average 70 kilo person, that's about 100 cc bolus. You start an infusion right away, and the infusion is started at 0.25 ml per kilo per minute, usually about 18 cc's. You really don't have to put it in a pump, just eyeball it on a roller pump. If the cardiac problems do not resolve, you should repeat the bolus for persistent cardiovascular collapse and double your infusion rate, and you should at least continue the infusion for 10 minutes after success. Practice advisories that have been published by various societies. This is the practice advisory that was published from the American Society of Regional Anesthesia, and it is basically a summary of what we just discussed. There is another advisory or another guidelines that has been published by the Society of Great Britain, and they essentially follow the same sort of principles, but it would be good where you do your regional blocks to display these guidelines prominently and have your checklist so you can proceed with your resuscitation promptly and don't have to rely on your memory, as we said. These are some of the other resources that you can get on the internet. lipidrescue.org and the ASRA website have important information. Thank you.